It is now my distinct pleasure to introduce our keynote speaker, Dr. Ariel Cole. Dr. Cole received her medical degree from the University of South Florida in Tampa and completed her residency and fellowship training at the Florida hospital, now Advent Health. As part of her role as director of the Geriatric Fellowship, Dr. Cole supervises medical students, residents, and geriatric fellows in the care of elderly patients in outpatient settings and nursing homes. She oversees a comprehensive geriatric assessment clinic where elder patients and their caregivers meet with an interdisciplinary team to evaluate their medical, functional, and psychosocial status. Dr. Cole is the Orlando campus clerkship director for geriatrics at the Florida State University College of Medicine. Dr. Cole is a member of the American Academy of Family Physicians, the American Geriatric Society, and the American Medical Directors Association. She is board certified in family medicine and geriatric medicine and is a certified medical director. Welcome, Dr. Cole.
Thank you. Thank you so much. Truly honored to be here. Y'all have welcomed me, and I have enjoyed my time here so far. So thank you for having me, and let's talk about dementia. I'm going to try to move quickly to have lots of time for questions. I've already had a good dialogue with some of your students as we met in a small group, so I anticipate more good questions as the evening goes on. But this is the agenda just briefly. We're going to talk about the evaluation of memory loss, different types of dementia. We're going to talk about treatment options and some of the challenges in managing patients with dementia. Of course, I'm coming at this from a perspective as a geriatrician, but I very much believe healthcare is a team sport, and that we need all of us informed and compassionate. I appreciated the thoughts of that invocation very much, as we all rely on our greater sources of wisdom in the care of our patients. So let's start briefly as far as memory loss is common, but it is not normal. Memory loss is an indicator of something going wrong with the brain's normal functioning, right? So tragically common, but not normal. And so a patient who's concerned about memory loss, or perhaps someone around them is concerned, because some people have insight into their own limitations and others not so much. And so, they deserve a proper evaluation. And that always starts with a history and physical exam, right? How long has the memory loss been going on? What are the symptoms that you're noticing? How is this having an impact on someone's daily life? And then a physical exam that typically focuses on neurologic, right? Because the brain is the central nervous system, but the peripheral nervous system is driven by that central nervous system. So doing a proper neurologic evaluation. And then cardiovascular are the main risk factors some of the main risk factors for brain dysfunction, right? Strokes being a common cause of memory loss. So, and then what other symptoms can help guide a differential diagnosis, right? The decision tree of these things are common, but what else could possibly be going on? Medication review, I think that's an important part. I think many of our patients take more medications than are helpful. The medical term is polypharmacy. Everything gets added on, and we end up in sometimes in a prescribing cascade of adding new medicines to treat the side effects of the last medicine. Occasionally that's absolutely necessary if that last medicine is critical and no other options are available, but often that leads to excessive medication, and that can affect memory. And then we want to evaluate for depression, delirium. Hearing and vision changes can really affect how a person interacts with the world. And I occasionally get that. I joked about the daughter from California earlier with the students, but the daughter from California who's worried about mom or dad because some of the latest phone calls, not answering questions appropriately. Didn't hear the question appropriately. How do you stand a chance at answering it appropriately, right? So these are some of the things that that we got to include. Not all memory loss is dementia, right? So there are unfortunately no shortage of tools to evaluate a person's memory. These are some of them. Maybe the MMSE, the Mini Mental State Exam. I personally use the MoCA quite a bit. MMSE is copyrighted. MoCA is not. Neither is LUMS. MoCA stands for Montreal Cognitive Assessment. There are a lot of different tools out there. There are ones that are much more detailed that I don't have really time to do in a typical office visit, that are 100-point scales or more, but are used in research and more valuable in that they can tease out, the differences. So I point out that there are a lot of different tools available. I think a patient with concerns around memory that we feel are valid and concerning, we should move on to do some basic labs. Want to check out liver and kidney function, check out thyroid function. We typically include a vitamin B12 level, because that causes neuropathy, right? Nerve dysfunction. Typically would have some other symptoms involved, including the peripheral neuropathy and things. When I went through training, myself here, a test for syphilis was kind of part of the standard evaluation. Now that's really included more on a risk factor basis, and those who have risk factors for syphilis, we probably ought to be considering HIV as well, as a part of that. So more targeted testing depending on risk factors, right? Maybe heavy metal exposure as a part of an occupation or something like that. That might be included, not a part of the standard evaluation. I do consider imaging a part of the standard evaluation. That's acknowledged by the American Academy of Neurology and such as well. Many of my patients have had a brain imaging as related to a fall or an ER visit. It happens pretty commonly. So if an image has been done during the course of their memory loss concern, say it's been about 2 years that I've seen some decline in memory. If a brain scan's been done, then I don't typically order another one. If that brain scan was 10 years ago, then I think it's worthwhile to check again. What are we looking for? I did see a study once that looked at the standard evaluation and how often that it shows something that we didn't expect. About 1 in 10. But how often does addressing that, what we didn't expect to find, maybe the thyroid's off, the kidney function, the brain scan, how often did addressing that reverse the underlying memory? 1 in 100, right? So this is a standard medical workup, and it's the right thing to do by our patients, but rarely do we find something that then fixes the underlying cause. Because the bottom line is hypothyroidism and dementia are common, right? Like there's this rule of parsimony, right? Occam's razor, find the one diagnosis that explains all the symptoms. Well, the opposite is that older patients can have as many problems as they darn well please, because that's the reality of taking care of older people, that they don't always just have one problem, right? So, and we'll talk a little bit more about the newer brain imaging that's available. We can now radio label amyloid and do a PET scan and look at the amyloid burden in the brain, which has become more important now that we have new tools that address the amyloid specifically, the newest medications that have been FDA approved just in the last couple of years. And we'll loop back around to that toward the end when we're talking about treatment. So I said not all memory loss is dementia. So there's the concept of depression presenting as dementia. And it can be difficult to tease out which is which, right? I think it's actually vastly more common that they coexist. But it can be difficult in addressing a patient who clearly has depression and memory loss. Is the memory loss just related to the depression, or is it some of both? And so, the right thing to do is to address the depression, treat that adequately, see the depression features improve, and then reassess the memory. Hypothyroidism, I mentioned, that's part of our standard workup. There are some very rare encephalitis and conditions. Those typically have a lot of other symptoms. I mentioned B12 is a part of our standard workup. Delirium. So when an older person has an acute illness, electrolyte abnormality, etc., often a hospitalization, but not always, that often causes some acute confusion that we in the medical field call delirium. And that doesn't always go away as quickly as we'd like it to, right? So think about what has happened in the course of this patient recently, and is this acute change, right? Delirium is more of a fluctuating condition, often has some hallucinations and other features. So part of the differential diagnosis, you're considering someone with some memory loss. I mentioned hearing or vision impairment, right? Are they not able to accomplish the tasks that they used to? Dad might have dementia because just not mowing the lawn anymore. Well, let's think about the other factors that might mean he can't mow the lawn anymore, right? Drug effects or intoxication. So I think I'm forever assuming that the precious elder person in front of me isn't possibly drinking to excess as a part of the explanation for the falls or confusion or things like that. And so I have to check myself and always ask, right? And I think I have a slide on medications coming up next. Normal pressure hydrocephalus. This is an unusual condition of the buildup of the CSF, right? The fluid that surrounds the brain and spinal cord. It's unusual, but it's a cause of cognitive impairment and some other symptoms. Probably some of you guys are reciting the triad, red, urinary incontinence and gait disturbance along with memory loss is the classic triad for NPH. Subdural hematoma. So again, many of our older patients have falls. Sometimes that gets checked out in the ER with the CT. Sometimes it's not, right? Many of our patients are on anticoagulation, so it takes less trauma to the head to cause a subdural hematoma. So occasionally we find those when we weren't necessarily expecting it. And my clicker is not working anymore. How we do? Okay, brain tumor. This is what everybody's scared to death of. I have yet to find a brain tumor in a patient that presented with memory loss. Can't say it would never happen, but very, very unusual. Mild cognitive impairment is in the vast majority of cases an early predecessor to a dementia process. There are a few patients that seem to have some cognitive impairment and remain stable there. I suspect that's an encephalopathic event of some sort, a hypoxic event like that. But that's a big area of research. Medications. So you've probably already guessed that I have a little conflicted relationship with medications. I think in some cases we do more harm than good, right? In a polypharmacy situation, and anticholinergics are part of my target. So everybody knows what a narcotic is. You guys know what a benzodiazepine is, right? Anticholinergics are sort of sprinkled throughout many of the common prescribed medications. Such that patients who are on lots of medications often have a pretty high total anticholinergic burden because they add up, right? There are a few medications that are in and of themselves strongly anticholinergic. The bladder muscle relaxant, the overactive bladder med, right? The classic ones, the ditropan, detrol, etc. Diphenhydramine, this is over the counter. This is Benadryl. This is what's in Tylenol PM. This is what makes you tired. Sleep is a whole nother lecture. We'll do that next time. But it's available over the counter, so everyone thinks if it's over the counter, it must be safe. But in truth, it reduces the way it makes you sleepy is by reducing your acetylcholine, which is one of the neurotransmitters, right? The main class of medications we have for Alzheimer's that have been around for 30 years are the acetylcholinesterase inhibitors, right? These drugs try to increase the amount of acetylcholine in the brain by inhibiting the enzyme that breaks it down. Acetylcholine is good for your brain. Acetylcholine is a neurotransmitter. It helps talk to each other. So by taking anticholinergics, you're contradicting that, right? So I am here to preach against long-term anticholinergics. if they can be avoided. And then the other medicines that tend to slow anyone down, right? Has anyone ever taken a narcotic for a pain after surgery, thing like that? You get a little sleepy, you get a little tired, right? So think about medication and adverse effects as a possible cause. All right, so moving on to dementia itself. Everyone, I get asked, I think once a day, what's the difference between Alzheimer's and dementia? I don't understand those terms, and it's confusing. So this is courtesy of the Alzheimer's Association. As we use it in the medical field, dementia is an umbrella term for the diseases that cause progressive cognitive decline. Alzheimer's is the most common type of dementia, probably in the range of 70%. Depends on the study you look at, a little more, a little less. But there are other causes. Vascular dementia is the condition of multiple strokes causing cognitive decline. Lewy body's probably under-recognized, underdiagnosed. It definitely has some similar features to Alzheimer's. It has some early Parkinsonian features that isn't true Parkinson's. They have a more rapid decline. They also classically have some visual hallucinations. Often see people or children, and in some cases aren't particularly bothered by the hallucinations. And so that isn't typical of especially early Alzheimer's. Frontotemporal, we'll talk about that, a younger age of onset, and then we have some other conditions like Huntington's, and more unusual prion diseases and such. Fairly common to see patients with a mixed etiology. Alzheimer's kind of presentation, evidence of strokes, so some of both, right? All right, so briefly, Lewy body dementia, as I said, maybe 10 to 15% of patients. They have much more fluctuating cognitive performance. Everybody's got good days and bad, but in general, for an Alzheimer's patient, if they weren't oriented to date yesterday, they're not going to be oriented to date today, right? It's about the same. Lewy body much more up and down. I mentioned the Parkinsonian symptoms. You guys know what Parkinson's is. It's a of neurologic decline affecting the periphery as well. It's classically a pill roll tremor, kind of a shuffling gait, right? A bradykinesia, meaning all the movements are slower. So any movement. A flat affect, meaning their facial expressions are very much diminished. And all of that comes on together in a body dementia patient. Vascular dementia, again, maybe 50% of all dementia patients, acute onset, sort of stepwise deterioration with strokes that sometimes are diagnosed and sometimes aren't recognized as strokes, right? And these are happening typically in patients with risk factors for strokes. So that would be vascular disease, diabetes, hypertension, right? Typical risk factors for stroke. Frontotemporal, this is an unusual 10%, maybe less. Earlier age of onset, classically in the 50s and 60s, so kind of tragically young. You can see in this post-mortem of a brain that you can see the nice, healthy, fluffy brain tissue in the posterior part of the brain, and then the front of the part of the brain that those sulci and gyri, they look thinner, right? So it disproportionately is causing shrinkage of the brain in the frontal and temporal parts. What does the frontal part of your brain do? That's important for social, right? Social norms, interacting with other people. Don't wear your pajamas to Publix. Think it, don't say it, right? My boss just did something I don't like, but I'm not going to tell him what I really think because he's my boss, and that would be counterproductive, right? So those inhibitions. So in some ways it becomes a little bit childlike, because if you don't have those inhibitions that say choose the salad for lunch, because that would be the healthy option, you'd eat like my 11-year-old, right? Like if I let him eat cookies, he would eat cookies 3 meals a day because he's 11. And what's better than cookies? His frontal lobe's a little underdeveloped. So there's some regression, right? And disinhibition. And those behaviors tend to really alienate, right? The loved ones. Because again, that think it, don't say it doesn't kick in. And then the temporal lobe is language, right? Auditory processing. I'm seeing you guys nod. You guys are learning this stuff. It's cool. And so that begins to be affected as well. And some stereotype speech patterns and behaviors there. So difficult illness to manage. All right, Alzheimer's disease. The most common cause of dementia, probably is in the 70% range. Unless you're specializing in pediatrics, you're going to take care of older adults, the healthcare field, and you're gonna interact with patients with Alzheimer's. It's projected to be 16 million by 2050. This is a disease of older adults. The vast majority of cases are over age 65, maybe 4% in younger, and that's just in most cases just onset tragically young. So I've got a world map up there, and the disease deaths per millions in 2012 due to dementia, including Alzheimer's. And that you see the burden is heaviest on more developed parts of the world. I think that's in part because of longevity, right? We're more successful at treating chronic illness and allowing people to live long enough to get Alzheimer's. And probably some degree of better accounting as well, better acknowledging of cause of death and contributing factors in developed parts of the world. But certainly Alzheimer's is a global epidemic. More than 5 million Americans are living with this disease. By 2050, this number could rise as high as 16 million. It is the 6th leading cause of death in the United States. Every 66 seconds, someone in the United States develops this disease, and it is the only of the top 6 causes of death that has no way to prevent, cure, or even slow the illness. I guess that statement is now a little bit controversial because the newest medications are being labeled as disease-modifying drugs. I personally am not sure I'm buying it, and I'll let you decide with the data that we have so far whether you consider them disease-modifying either. But I mean, it is impressive to me how far we've come in so many diseases, right? Cancer is just amazing, the new biologics, what they can do. And obviously we've built on decades of research of chemotherapy and effective treatments for various types of cancer, certainly heart disease. Some of the newer medications are very impressive in managing heart failure and heart disease. Clearly HIV, we're light years away from where we were decades, and thankfully so. I believe smart people have been working all along on all. I trust that if this was easy to solve, somebody smarter than me would have solved it by now. That this is complex. That the human brain is kind of the last frontier in medicine that we really don't completely understand, including other types of mental illness. I feel like I sincerely hope this lecture is completely antiquated 10 years from now. Like that's the way it is in medicine, is that we are developing, we are changing. There are new horizons, and I'm hoping people smarter than me are working on the cure. All right. This is a picture of, and I'm not going to pronounce her name correctly because I don't speak German, but her name was Augusta Deter, and she's in an asylum in Frankfurt, Germany, in the early 1900s, the very early 1900s. And Dr. Alois Alzheimer thought she was a very interesting case, because he was a psychiatrist, and so he was accustomed to treating mental illness, and the majority of those illnesses have an onset in younger adulthood, right? But Mrs. Deter had been married, raised a family, lived a pretty typical functioning life until she was in her 60s, when she began a decline in her cognition, in her memory. And so he studied her and got permission to examine her brain after she passed away, and wrote a paper about the neuritic plaques and amyloid beta depositions that are still the hallmarks of Alzheimer's disease to this day. And I think what really strikes me about her picture is how much she resembles some of the patients I rounded on at the nursing home this morning, right? Alzheimer's disease, I think you probably know intuitively that it's the more complex tasks that are affected first, those that require higher levels of executive functioning, like managing your finances, organizing a meal, right? Maybe you're serving Thanksgiving dinner, you got to plan ahead, you got to shop, you got to sequence a bit, right? Those more complex tasks are affected earlier in the disease process, and then later on, maybe like organizing hygiene, coordinating clothes for the appropriate weather or the event, actually physically dressing yourself, using the toilet. So it's somewhat in reverse to what a little child learns, right? So that can help us recognize what's coming, what's next. And this is why, right? There is global degeneration. This is a cross section of a healthy brain versus a patient who died of severe Alzheimer's, and the brain tissue literally dies. It's a tragic consequence of this degenerative illness. This is a standard PET scan that lights up glucose, right? Radio-labeled glucose in a standard PET scan. So on the left there, you see an active brain. It is using that glucose. It is processing. On the right, you see very little of the red activity. The brain is just not able to function normally. All right, I'm going to talk through the primary staging system that we use for Alzheimer's disease. And unfortunately, just like there's no shortage of cognitive tools, there's really no shortage of staging systems for Alzheimer. It's, I guess, an opportunity to get published is to come up with the new staging system and write an article about it. But this is the one most commonly used, especially in research studies. And I'll point out that 1 and 2 are really normal functioning, right? That most people don't actually have symptoms such that they will be noticed till stage 3. So 1 is no cognitive impairment. 2 is very mild decline. Maybe the person themselves will notice a change, but then again, we all have bad days, right? Please tell me I'm not the only one who's ever walked into a room and thought, what did I come in here for? Or placed something and found it later and thought, oh, okay, I remember coming in here and this is where I set it down, silly me. So that's the stage 2 is at, right? How is that different from normal? Pretty much not. So stage 3 is a significant change from baseline. Some word or name finding, again, that is common with normal aging. Word or name finding problems are typical, but a decreased ability to remember names when introduced to new people, some performance in social settings, may be noticeable to others, reading a passage and forgetting the material, losing or misplacing objects. Again, these are all still fairly common symptoms, even with normal aging. You can see why it's pretty hard to tease out, is this an early part of a disease process, or is this normal aging? Stage 4, now is when we get to more significant cognitive impairment. So some clear-cut deficiencies, increased knowledge of recent events. Your cousin visited last week, you may forget about that visit. Impaired ability to perform challenging, like arithmetics. Counting backwards from 100 by 7 is a fairly standard part of the evaluation. Don't practice that. They'll change it by the time you get there. Complex tasks, memory of personal history. So, I asked a patient, when did you have that cabbage surgery or your heart disease surgery, and he said, well, I think I had it in 2011 because I had my hip replacement in 2010. And his wife was, doing the nope, flip them, like you had the cardiac evaluation before they did your hip, and then they found out, and that's why we did the heart surgery before the hip surgery, right? All right, so stage 5, moderate to severe cognitive decline, unable to interact with a medical interview, recall those events, right? Becoming confused about where they are and why they're there. Again, difficult arithmetic tasks, maybe difficulty choosing proper clothing for the season, usually still retaining substantial knowledge about where did you grow up? How many siblings did you have? What was your profession? Those things they're able to. It's the distance memory that's more preserved, right? And you'll often hear families say that, oh, well, he can tell you everything about, college and playing football and yada, yada, right? But what about, the cousin who visited last week? Well, that's where we're having trouble, right? All right, stage 6. This is more severe, lost names of maybe even people they well knew. Personal history begins to be affected. You can see some of those symptoms there. Sometimes this is where a disruption in the normal wake cycle comes in. That can be really challenging to manage from the caregiver perspective. Maybe some difficulty managing urinary continence, fecal continence, some difficulty processing even what those symptoms, what that feeling is and what to do with it. And then stage 7, this is the last of these stages in the stage. And this is where they're going to have difficulty even coordinating things like walking, toileting, and continence, and eventually even the ability to interact and swallow. All right, so moving on to treatment. The medications we've had for a while are the cholinesterase inhibitors and memantine. I'm going to touch on the anti-amyloid monoclonal antibodies, those new kids on the block. And then I'm going to touch briefly on medications to manage symptoms that we use mostly off-label. Cholinesterase inhibitors, you see the generic and brands there. Donepezil and rivastigmine are the most common on the market. The galantamine has a lot more GI side effects than the others, so kind of fallen out of favor. As I told when we talked with the small group of students, my spiel on introducing these, as far as is this something you want to trial, is they do make a difference. It was scientifically proven. That's why they got FDA approved. When they do these trials, they put 100 people on the medication and 100 people on placebo, and then follow them, right? Well, both groups got worse over the next months. It's just that the group on medication tested 3 points higher on a 100-point scale. So that doesn't correlate to a clinically significant difference, generally speaking. Does it slow the disease progression a little bit? Arguably, yes. And then I think it's, an individual person and their family members' decision whether it's worth a trial of the medicine for them, or I don't like taking pills and I don't want to deal with it, and you get no argument from me. But at least they have the advantage of being inexpensive, around a long time, so we have a pretty good safety track record. And so that's available in an option. Memantine has also been around for quite a long time, 25, 30 years. It works a little differently than the cholinesterase inhibitors. It works in the NMDA pathway. So a little bit different neurons helping the brain communicate. Can be added on too, because it works differently, right? You can use both. It is only approved, Namenda is the old brand name. It is only approved for moderate to severe. They couldn't prove that there was any effectiveness in the mild. I assure you, they wanted approval for all that they could get back when it was branded and expensive. Just a brief note about genetic testing. We do know that there are genes involved in Alzheimer. The main ones that are well documented are the ApoE4 alleles. So we all have 2 ApoE alleles. You got one from each parent, right? They are just coded as 2, 3, and 4. 2s are somewhat protective, 3s are neutral, 4s are increased. Got 1, 4. If it's balanced by a 2, you're lucky in that, right? You've got 1-4, you've got maybe a 5% increased risk over the general population. If you're double 4 alleles, your risk is more like 20% more than the general, but it's not a guarantee by any means, right? This is not a deterministic gene. There are other genes that increase risk, presenilin being one of them. There are very rare families with an autosomal dominant pattern of a determinist that, interestingly, overproduces amyloid. And these families represent less than 1% of the Alzheimer population. In these families, it's easy if you know a family history, a very profound pattern of very early onset. I mean, very early onset in my world, it's in the 50s, right? I see a 60-year-old, I'm like, you're so young. So very strong family history. There's an interesting area of Colombia that's been studied extensively because there is a family there that seems to have this autosomal dominant pattern. And so, again, very, very rare. New developments in lab testing. So hot off the presses. So there are direct to consumer, right? The big lab companies, Quest, LabCorp, have packages of serum testing that does show markers of neurodegeneration. It's not specific, right? There are multiple causes of neurodegeneration, but and so it's not marketed, not FDA approved, not insurance covered at this time. Maybe it will be. I don't predict you're any better than anybody else. But this is new, and I'm a little freaked out that we're kind of going with this direct to consumer. I get it that that's where the money is. But now I have people kind of coming in with the lab tests saying, what do I do with this? And I'm not sure I have good answers yet, right? Because the science isn't really there to understand these non-specific neurodegenerative markers and what the implication is for an individual, right? But they may be helpful in patients with cognitive decline to document the neurodegeneration that may be there. All right, so now let's talk about the new drugs, the new kids on the block. So the first one to be approved was back it was the first new drug since 2003. It was FDA approved in June of 2021 under the accelerated approval pathway. This under brand name Aduhelm, right? Aduhelm is the generic drug. Outrageously expensive, right? Shockingly so. Originally marketed at $56,000 for the drug alone, and it's an IV infusion, and you darn well better prove that they've got amyloid in the brain before you put them through this, right? So that means an amyloid PET, which is outrageously expensive. And then just the follow-up on this is, I mean, I do dementia, right? This is what I care for, and I couldn't keep up with these protocols as they're written now. You really need to be in a study and high rates of ARIA. I think I've got that on the next slide. So I thought it was kind of cool. This group did a study in JAMA. So they just looked at the Medicare cohort of mild cognitive impairment in Alzheimer patients, right? So data points on everybody in Medicare, and said, how many of these would have been excluded from that trial? 92%, right? If that doesn't reinforce to you how different the patients we care for every day are from the ones they do in the studies. And I get it. If I wanted to prove my drug worked, do I want a cancer patient in my trial for Alzheimer? No, you're likely to die of your cancer before I can prove that my drug worked, right? Do I want people in my trial who have kidney disease and heart failure, and right? Like, so they pick the cleanest, and I understand that, because if you pick the real, it's muddy. But yeah, excluded patients with cardiovascular disease, excluded everyone on anticoagulation, and huge percentages of my patients are on anticoagulation for various cardiovascular reasons. But I know why, because these drugs cause bleeding in the brain, and patients have died due to bleeding in the brain that is undoubtedly due to these drugs. Yeah. So it turns out yanking all the amyloid out of the brain is a little dramatic, and they're very effective at yanking the amyloid out of the brain. They really do work for that outcome. But that's not the outcome we care about, right? The outcome we care about is cognition and function, and it helps there too. So two main trials that the FDA approved, the Aduhelm based on the Engage and Emerge, and there's controversy here, right? Because one of the trials showed some improvement and the other really didn't. This is not without significant hassle burden, right? IV infusions once a month for 18 months. About 41% of patients had ARIA, amyloid-related imaging abnormalities. 35% had edema in the brain, 19% had microhemorrhages. That's small, but that's bleeding in the brain. Bleeding in the brain is not good. Most of them were asymptomatic. So the disease is horrible and the treatment's hard. Ugh, right? Leqembi, a little better. Most recently, the newest one approved just in July of last year. Both of these drugs are only approved for the very earliest patients. They are not effective. They are not approved for more significant severe patients. That's partly why 92%, the total Medicare dementia population would have been excluded. Many of them would have been excluded because they're already too far along. I don't know why they only work in the earliest. Maybe too much damage has been done. Like we just don't understand yet. But you really have to, there's a big focus on capturing patients early. So they're at least, this is at least an option. And you hear me like dissing on these drugs. And I think, we ought to have a healthy schedule. But I'm not saying that I wouldn't ever, want a patient to try it because, I don't have something better to offer, right? I just think people ought to understand the risks and benefits, right? Make a decision for them. But so Leqembi's a little cleaner. It's a little more hassle every 2 weeks. These protocols, I think this is the way we're going to go because Leqembi's main studies said, let's treat to amyloid negative and stop then. Don't have a blanket, everybody gets 18 months of these drugs, right? If you get to amyloid negative in 9 months, let's stop the drug, right? Like no point in doing another 9 months. If it takes you 12 months, that's when we stop, right? So that makes sense. So let's individualize and then stop the risks and the hassle and the expense when we've gotten the amyloid out. It will be very interesting if the focus shifts from treating symptomatic people, which is what we've done so far, to actually screening for amyloid pre-symptomatic and treating then. I'm going out on a limb here. I don't know, right? Like those studies need to be done. All right, moving on. 90% of patients with dementia will have behavioral problems in the course of their state. This is what really makes it challenging for the care partners, right? Common behavior is paranoia, wandering, care, hallucinations. This is what makes it challenging for us in the healthcare field to interact and really care for these folks. And we don't really have good pharmacologic tools. The main interventions really need to be non-pharmacologic. What does that mean? When I was talking with the students earlier, I had a daughter, calling in. Mom asks where her mom is all the time, right? Every day. Where's my mom? Why is she not? Well, mom has been passed, right? Mama passed 20 years ago. It's interesting how the brain just kind of regresses to previous times. Many of my patients, I want to go home. Well, this is home, Mike, right? You've been here we've lived in this house for 6 years. This is home. But the brain, the home that there is a childhood home or a previous home. And so those are the worries. Those are the thoughts. If you were worried about where your mama was, right, then you'd be asking that too. It's okay to not say mama died, right? It's okay to say she's okay. We'll check on her later. Let's listen to some music. Let's go for a walk. Let's have a snack, right? Like let's change the scenario. For some people, some of these behaviors are out of boredom. And then for others, it's I'm overstimulated. I need some rest, some break. So it really needs to be individualized, which is why this is hard, right? Like why there's not a one size fits all as far as non-pharmacologic interventions, but truly the best initial step for managing challenging behaviors is getting the caregiver involved in looking at what the triggers might be, changing that situation. If it's sundowning and those evening hours are the worst, how do we make it best, right? How do we load that time with the best parts of the day? Safety issues, gosh, we could do a whole hour on driving. Driving is independence. We don't have good public transportation especially for somebody with cognitive impairment. So taking that away before it's necessary, that's huge. Imagine if any of you were not able to drive tomorrow, right? How much your lifestyle would change. Mine too. And there's more to driving than just cognition. It's physical reaction, it's vision, it's planning. Falls are very, very common, right? And a huge cause of morbidity and mortality, falls and fractures, cooking, fire risk. I have lots of patients whose stove just doesn't work anymore. It's been unplugged, right? Like it's been disconnected. The microwave, I mean, you can ruin your food in a microwave, but at least you're not likely to set the place on fire. Wandering's a big challenge. Firearm safety, and kind of like asking about alcohol use, I probably should be asking more about firearms in the home, especially for somebody who's having hallucinations or paranoia. Had a caregiver tell me not long ago that she woke up to the sound of her husband had bought a taser gun, and he was having hallucinations, and so he thought there was someone in their room, and thank God it wasn't pointed at her. She might have been tasered. So yeah, suicide risk, right? Older adults have the highest risk of completed suicide, right? Younger teens attempt more. Unfortunately, older adults are successful more. Some legal issues. One of the great arguments for making a diagnosis early is empowering persons to make advanced directives and make their wishes known as far as the types of treatments that they want or don't want later in life. Because if we let the disease progress too far, they really can't, participate in that conversation. Designating a healthcare surrogate or a power of attorney, that living will, and that because, as the disease progresses, evaluating that decision-making capacity, many of my patients may not know what the date is today, but they may still be able to say, this is my daughter, and I want her to, care for me and make decisions, right? So that capacity may not be able to make a complex decision about, you've got a pulmonary nodule, should we watch it, should we biopsy it, right? Like the risks and benefits, but still make some decisions. So there really isn't a cognitive evaluation score that says, if you got above 20, you can still make your decisions, right? Like it depends. It depends. And then, obviously these persons are most tragically possible victims of abuse or neglect because they're not able to report that well. So that's something that we got to be particularly alert to. Caring for their care partners, I think is really a part of why this is a team sport. And really an important part, this is where I say geriatrics and pediatrics are similar, right? Because it's not just assessing and caring for the patient, but also their support system. And so sometimes that's a spouse who also is dealing with their own health issues. Sometimes that's children. Hopefully that's a team, right? And there are community resources and there are national resources. And if there's any silver lining to COVID, it's that we've all learned how to tap into and communicate with, you can have a great, care partner friend who lives in Chicago or New York or wherever, but is dealing with similar things, and y'all can, meet online and support each other, because there's a lot of caregiver education. The Alzheimer's Association has a good organization with a website, a 24/7 free helpline that everybody who's a new diagnosis in my office goes home with a brochure on, and other resources to start learning. I think it is valuable to give people a name to what they're dealing with, even if it's a best guess, right? And this is a clinical diagnosis. I wish there was a blood test or a brain scan finding that says, put a check in the box and says, yes, this is Alzheimer's, or no, it's not. It's still a clinical diagnosis, but I think, even with that caveat of, I think you have Alzheimer's, or I think you have Lewy body, I try to give patients a name so that they have the ability to kind of tap into those resources. End of life issues, dementia is a terminal illness. Arguably, life is too. All of us are going to pass away of something someday. I've got a colleague who's pretty commonly quoted as saying, you got to die of something. So hospice criteria are pretty strict. It's a disease that can have a really long, slow progression. So it's hard to predict when somebody's truly in those last 6 months of life, as is the criteria for hospice. But yeah, end of life care can really be an ongoing challenge for our caregivers and their loved ones. Many patients, their care partners will ask, well, how do you die of Alzheimer's? Well, you tend to die of the complications of it, right? When you can't move anymore, then you tend to have some skin breakdown. When you can't swallow anymore, then you aspirate, and that goes into your lungs. Or you tend to lose weight, right? The appetite and the desire to eat, ability to eat decline. And no, I don't think that means we should put a tube in your stomach, because that doesn't benefit the underlying disease processes in a way. I think most of us would agree that one of the pleasures of life is a nice meal, something that tastes good. And so taking that away, I think is unfortunate. I'm not against tubes under any circumstances, but I think they're not helpful in stage dementia. And I think the literature supports that, even in light of weight loss and such. So wrapping it up here, memory loss certainly warrants a careful evaluation. It is common, it is not normal. It should be worked up and diagnosed appropriately. It's a very challenging condition for healthcare providers and caregivers. This is, I think, where we really all need to be on the same page and working for our patients and their care partners' best interest, and with a fair amount of sensitivity and support to what they're dealing with.
Thank you. How about another round of applause for Dr. Cole? Fantastic. Thank you. I also want to thank again Dr. Rich Orlando and his wife Cindy for helping bring this event to our campus here in Erie. I really appreciate all of you being here. I appreciate those that have joined us online. Your engagement in these type of sessions that you're starting now, you're setting habits for your professional careers. And I can't stress enough, this is the difference between being good and being great. Bottom line, you all can be really good OTs and PTs and SLPs, PAs, but are you going to be great people? And are you going to practice with compassion? And I'm going to stress right now, folks, this world needs really, really great people with compassion. You guys have a great night. Take care of each other. Go Knights.